So, by way of introduction, many of you will absolutely know Dr. Norman Swan. If you're a regular ABC viewer like me and you listen to News Breakfast and CoronaCast and the Health Report, so he probably needs no introduction, but I will introduce you anyway, Norman, and say we are beyond delighted and grateful that you've given us your time, because, you know, I have some idea, given that I follow you quite a bit on various forums, just how busy you are. So making time for a non-govy like us that has a big footprint across Australia for vulnerable people is critically important for us, and we're delighted to have you with us. So thank you. Thank you. So I'm going to ask you a first question just to get us going, Norman, which is, have you had your jab?
Yep, I had AstraZeneca. And by the way, I'm only too happy to be involved. It's a really important sector, and I think you've been a bit neglected by government and others, and that's outrageous. And that's why I'm committed to spending this time with you and helping answer your questions. So yeah, I had AstraZeneca, and I had my first dose, I think, in May, and my second dose early July.
Great. And you're alive and well, obviously.
Completely fit, yeah.
Great.
Anything that went wrong with my brain happened a long time ago before the vaccine.
I completely share that experience. I understand. Thank you. So look, we've had a lot of questions about drug safety, so I might go to a few of those as a starting point, if that's okay. So someone has put the question forward to us that historically it's taken 10 years to develop a vaccine to test the long-term side effects post-vaccination. Is it true that we're still in phase 3 clinical trials with these vaccines, which are not intended to be closed till 2023?
So the answer is no, we're not. Take me a little while to answer this question, and I think it's probably a foundation knowledge that we all need to understand what comes next from some of the questions you might get. I don't know what questions you're going to ask, but I get asked this question a lot. And it's true. What is absolutely true is that vaccine development usually takes a long time. And there are a few myths about the vaccine development in terms of COVID-19. Some people have the idea that the vaccines had to be developed last year, and they were developed and being tested at the same time. And that's actually not true. What happened a few years ago was that some people with foresight, like Bill Gates and others, knew that we were not ready for the next pandemic. They knew that the next pandemic was either going to be a coronavirus or influenza. And they knew that if it was a coronavirus, we weren't ready for it. And we had to have a vaccine, and a vaccine quickly. So they set up a competition, they called it a challenge, and they funded it. And what scientists had to do was come up with a technology for a vaccine that could produce a vaccine to a virus they'd never seen before, and do it within 16 weeks. That was the challenge. So they had to create a new technology that allowed them to do that, because old technologies didn't allow them to do that. They were very slow. They knew they had to move fast. So, and this was a few years ago. So 4 technologies won it. mRNA, you all heard of mRNA vaccines now. That's Moderna and Pfizer, and other vaccines that are going to come on the market next year. What are called, sorry to use technical terms, but viral vectors, which means, I'll tell you what it means in a minute, and that's AstraZeneca and the Johnson & Johnson vaccine. And the University of Queensland vaccine won it too, but unfortunately that was put to one side because of problems. It's a complicated story, which is a bit unfair actually. And there was a 4th one as well, which I think is the Novavax one. So those were the ones who won it, and they were dressed up, ready to go. It's like, Formula 1 cars on the starting line, vroom, 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 ready to go when the vaccine hit. Yeah. And luckily, what some of the Chinese scientists in Wuhan had sequenced the virus. They'd done the genetic code, studied the genetic code of the virus, worked out what it was. And that was actually released to the world by a professor at the University of Sydney called Eddie Holmes. He got it from a Chinese colleague, released it to the world. And within weeks, these people who had these vaccine technologies had actually developed the vaccine, because they knew it was going to be a coronavirus, or they suspected, and they knew from previous research that that little spike at the end of the coronavirus is what they had to head for, because that's how it connected to the body. So none of that was new information. They knew all that, and they knew if a coronavirus was coming, that's what they had to head for, that spike, all dressed up, ready to go. And so within weeks, they had worked out how their vaccine would work with that spike. Now, what happened then, it's true that phase 3 trials, so just to explain trials now. Phase 1 trials are to test safety. Really, there's a really big safety problem with the and you do that in a small number of healthy people. A phase 2 trial is where you test the dosage of the virus, of the vaccines, and a phase 3 is where you work out whether it works in the real world and whether it's safe. Mm-hmm. Now, normally that takes forever, because you've got to recruit people to the phase 1 study. There's no sense of urgency. You get that done. Then you've got to do the phase 2 study. Sometimes you've got to find funding to do the phase 2 study. And so you're stalled for a few months or maybe even a year or two before you get the phase 2 study going. And then if the phase 2 study works, then you've got to find funding for the phase 3 study. And that takes a while, and you've got to get ethics approval and all that. And you might not start the trial for 3 years. And then you've got to recruit people to a trial. And people aren't motivated. You know, why would I bother going in for a new influenza vaccine trial? What's in it for me? And it takes you forever to recruit the 40,000 people. You've got to recruit a lot of people for a vaccine trial to make sure it's safe. It takes forever. So that could take you another 18 months or a year. And then you've got to wait until people are infected with the virus naturally. And that can take a long time as well, because there might not be any virus around for a while. What was happening here was it was a pandemic. There was plenty of money around. So they were able to do the phase 1 studies like that. The phase 2 studies were a bit shorter, and I'll come back to that in a minute. But they're not safety studies. They're to work out the right dose. And that's why there's a little bit of confusion about vaccines at the moment. I'm just trying to be as transparent as possible here. But they wanted to get to the phase 3 and make sure they really made sure they were safe and effective. They really worked. Now, because there was money, and because we're in a pandemic, people all over the world, Brazil, South Africa, Britain, America, Australia, were willing to take part in these trials. And they recruited, each of these vaccines recruited at least 40,000 people, sometimes much more than that, to their clinical trials. And they did it with it like that. And then, unfortunately, because we're in a pandemic, there was so much virus around, they knew, instead of waiting years for people to be naturally infected, they were infected within weeks. So within weeks of the clinical trials starting, they knew whether the vaccines worked or not. And then they went on for another 2 or 3 months to make sure they were safe. Now, what's known from these other vaccine studies in the past is that if there are serious side effects, so first of all, the randomized trial tells you whether you've got a serious side effect at a rate of about 1 in 40,000, because there's 40,000 people in the trial. It's actually a bit less than that, because half the people are on placebo or a dummy vaccine, and half of them are on the real vaccine. So it's maybe 1 in 20,000. And so whether it was safe at a rate of 1 in 20,000. So it's well known that clinical trials don't pick up rarer side effects than that. They can't, well, they very rarely do, because just because of the play of chance, 1 in 20,000, you're not going to pick up a 1 in a million problem or a 1 in 60,000 problem. Now, what we do know from previous studies in these slower trials, which are really slow because of circumstance rather than that's how long it takes. It doesn't need to take that long, as we've shown, because at the end point of the phase 3 studies of these vaccines, they had exactly the same level of evidence that any vaccine has had in history. Even though it might have taken 10 years, after 10 years of work, they would have got to the same level of evidence that we got to with these 3 vaccines, the ones that we're talking about in Australia, that we got to by November, December of last year. Just took them longer.
Yes.
Now, what happens then, and I apologize for going on a bit about this, but it's really important information, is that what we know now from the studies that took longer is that if there are any other serious side effects, they appear within 6 months. They don't appear in 5 years, 10 years, they appear within 6 months. And what we've had with COVID-19 vaccines, which we've never had with any drug or any vaccine in human history, is the ability to monitor how it works and how safe it is in vast numbers of people. So I think the latest number is 6.8 billion doses of these vaccines have been administered worldwide, so almost 7 billion doses. And it's like a goldfish bowl. They're watching this closely. So we now know what the side effects are. So we know with Astra, for example, there's a 1 in a million chance that you will die of a blood clot. We also know, by the way, if you in Australia now, if you are unvaccinated and you catch, just remember that number, 1 in a million. Remember that you also get a heart inflammation with Pfizer for young men. That's 1 in 50,000. So if you get infected with COVID-19 and you're unvaccinated, I know the hospital rates have gone down, but they've gone down because of vaccination in the population. If you look at unvaccinated people, take them out of the statistics, you've got a 1 in 10 chance of ending up in hospital, a 1 in 50 chance of ending up in ICU, and a 1 in 100 chance of dying, versus 1 in a million or 1 in 50,000. So those are the statistics, and this virus is real, and you will stand a good chance of catching it. So we know what the side effects are, and we've never been able to monitor them. My theory is, you know, this problem of clotting with Astra and the heart inflammation with Pfizer for young men. My theory is we would never have found out these side effects because they're so rare. And if we had found out about them, it would have been 5 years from now. And some blood specialist somewhere would have said, oh, you know, I've seen people with this funny clotting problem. And the only thing in their history is that they had AstraZeneca a month beforehand. Has anybody else seen this? And a few months go by, and somebody in Boston said, oh yeah, I've seen it. Somebody in London said, yeah, I've seen it. And then there's a warning for Astra, the same thing for Pfizer. But because of this intense scrutiny, we found these things early. So it's enormously reassuring.
Yeah. Thank you, Norman. And I must say that comprehensive answer, which was really, really informative, has actually answered a number of the questions that were put to us as well. So given that, I'm going to move on to a couple of other questions with a slightly different flavour that are a little more specific.
Can I just, sorry Barb, can I just amplify on one more thing that I said?
Certainly, of course.
Because it's really important to be transparent and not hide anything. I was the person who exposed the problem with Astra in Australia. The government didn't want me to. The Therapeutic Goods Administration didn't want me to. I got a lot of criticism for it. And I hesitated to do it. I think, well, it's going to make people frightened of Astra. But the reality was it was much more important that you were transparent about side effects to engender trust. The second thing I'll say is I want to come back to that comment I made about phase 2 studies. I'm sorry it's so technical, but it's actually important to understand. And it explains why some people are a bit confused about things. So if we've had the important thing was the phase 1 study, safety, phase 3 study, safety and effectiveness. The phase 2 study, where you try and find the right dose, is not so critical. And that's where they did shorten the process. And that's where a lot of the confusion has come in. You know, you probably remember people are talking about Astra. Is it better 4 weeks second dose, 8 weeks second dose, 12 weeks second dose? A lot of confusion about that. That's because they dicked around about the dosage and they didn't do a good phase 2 study. So they changed the dosage during the study. And it really wasn't until they did an American trial that they sorted out that 4 weeks is actually fine for AstraZeneca. But that confusion arose. Now, Pfizer, for example, they took a kind of best guess on it, and they decided that they'd go for a lowish dose of the mRNA, and they'd go for 3 weeks between the first and second doses, because they wanted to be sure it was safe. So they only wanted to give the smallest dose they could to get the best effect. Yes. And they wanted to get it quickly, because in a pandemic, you want to get the second dose in fast. Moderna went for a higher dose of mRNA because their thinking was, well, we want to really give the immune system some oomph here, and we'll go for 4 weeks, because they knew from other vaccines that a slightly longer period is probably better. And you know from your kids, you know, you have 2, 4, and 6 months. You have 2 months. You have 8 weeks between your 3 doses. So they went for 4 weeks and a bigger dose. And what's happened here is that Moderna actually gives you a slightly better immune response than Pfizer. And Pfizer is showing signs of waning, probably because it's a slightly lower dose given too quickly. And that's why you're seeing a bit of waning. I'm sure there are questions about booster shots that are coming up here. And Astra, there's been a lot of confusion about Astra, and probably 4 or 6 weeks is fine with Astra to get a pretty good immune response. I just wanted to expand on that.
Oh, thank you. And it leads nicely into another question, which was about the boosters and the either dose 3 or booster shot, whichever the terminology will be for various vaccines. So I think you've probably covered that reasonably.
Well, let me expand on this. A lot of vaccines are 3-dose vaccines, and I think if they'd had, coming back to the very first question, 10 years in time, and I think if they had time, they would have found out that the right regime, the right process for immunizing people to start with this, if we'd all had plenty of time and be able to do it, and it wasn't a pandemic, I suspect what would have happened was all the vaccines would have been 3 doses, like human papillomavirus for cervical cancer was 3 doses to start with, hepatitis B, children's vaccines, a lot of 3-dose vaccines around. They would have given them 1 dose every 8 weeks, and that would have been done and dusted. And many of you watching will have had a 3-dose vaccine regime, or your kids have had it. We're used to that sort of thing. So what we're doing now is playing a bit of catch up as we see how things evolve. And I prefer to talk about it as a 3rd dose rather than a booster, because it's really the dose. And that gets away from the guilt about not giving our extra doses to low-income countries, because they need 3 doses as well. So it clarifies it for them that if we're going to when we supply them with vaccine, we've got to supply them with enough vaccine for 3 doses. And we need 3 doses as well. And the research shows that it depends on 2 things in terms of how rapidly the immunity wanes: how old you are, and how sick you are as well. So this goes to your clients rather than you necessarily as disability workers. So if you are older, your immunity to the first 2 doses is lower to start with. So you get because your immune system doesn't work quite as well. So if you're 40, or under, or 50 and under, you get a really good immune response, really high, and it probably declines slower because you just got a healthier immune system. Over 50, but particularly over 80, the initial immune response is lower and it goes down faster. So the Israelis and others have shown that round about 6 months, if you're over 65, particularly if you're over 80, you're really in desperate need of a 3rd dose, because not only are you more exposed to infection, you're more exposed, you lose some of your protection, not all of it, to hospitalization and severe disease. So in the Australian context, so there'll be a lot of people watching who've had their vaccines. In the Australian context, now some of you might have had it early on. So the people who had their first, a lot of people, so there were people in aged care, residential aged care, not so many people in the disability section, which is terrible. But anyway, people in 1A, so frontline workers, healthcare workers, aged care workers, supposedly disability workers, and people in residential aged care got first doses around about March and April. And depending on what they got their 2nd dose maybe April, May. Okay. So then it starts declining month by month. So about 6 months after your 2nd dose, you're starting to need your 3rd dose. And so if you had your first dose in July, 2nd dose in August, you don't need to have to think about this really until February of next year. So this is a problem. This is a thing for you in the future. It's not a now thing. The people who need to be 3rd dosed are residential aged care, frontline workers, health workers, and so on. And that needs to start pretty soon. Unfortunately, the government's being a bit slow about that, but they say they're going to start residential aged care in a couple of weeks. My view is they should just be getting on with that now. And then the wave will follow through. And I'm often asked, well, what's the best vaccine to have if you've had it? So you're best to mix them, actually. And that we know that from other research into vaccines. If you mix the type of vaccine, it confuses your immune system and allows it to respond more assertively to the third vaccine. And there's just been recent research on that. So if you had Astra, you should have Pfizer or Moderna. Pfizer, you should have Moderna. Moderna, actually, there's a little bit of debate about Moderna. If you have Moderna, maybe you have a third dose of Moderna or Pfizer. Probably doesn't matter a lot, actually. And in Australia, we're only going to be giving Moderna and Pfizer as third doses, which is the right decision, regardless of what you've had.
Thanks, Norman. We've had a couple of people comment that they're waiting for the Novavax vaccine, and I just wondered if you have a view on that.
Yeah, I'm not sure why people are waiting for the Novavax. It could be a while. They say they're going to bring in the first. It's a good vaccine, by the way, and it'll probably be used as a booster in the Australian context. They've had problems manufacturing it, so it's a good, safe vaccine. They've had problems scaling up their manufacture. It's a very different vaccine from the others, and it's got a very complicated substance that attaches the spike protein to, and they've had trouble making that and getting approval for their manufacturing process. So I think they've got problems scaling up. So I think you're waiting for Novavax, you could be waiting for some time.
Yes.
And if we're opening up now, unvaccinated people are terribly vulnerable. You're going to catch COVID,
Yes.
and you're going to catch COVID in the next 2 or 3 months. And there's no guarantee you'll come off well with that.
No, thank you, Norman. That's really important, particularly for our sector, where there are public health orders now starting to mandate vaccination for our sector. So I think that's really helpful for us.
Yeah, and by the way, there's no guarantee that Novavax doesn't have rare side effects. And it's only when you put them into the market you know what rare side effects they've got. It won't have common ones. It'll be rare like Astra and Pfizer. And you just kind of got to accept that there might be rare side effects. We don't know that yet. And, but, you know, if it was here now, that's fine, but it's just uncertain when we're going to have it.
Yep, thank you. Now, just a little change of pace, because these are a couple of questions that are coming up quite often. And I'm going to combine them. As one is about the safety of vaccination when you're breastfeeding your baby, and the other one is around the COVID vaccination impact on fertility. So people feel they're getting conflicting information about both of those things.
Right. Well, there's no conflicting information about infertility. The vaccines have no effect on infertility at all. It's now been well studied. It's been particularly well studied in paradoxically in infertility clinics, where they've looked at the effect of the virus. Now, if the vaccine is going to cause a problem with infertility, the virus should too, because all the vaccine is doing is telling the body to produce a little bit of the virus. And if, now I know there's this story around that mRNA might react with your placenta or something like that. That's not true. There's just no truth to that. There's no what's called homology, genetic homology there. So it's just not true. A lot of this has been put out by anti-vaxxers. I mean, I'm the first person to accept when there's side effects. And if there was a side effect, I'd tell you, but there's no signal on that. And it's been really well studied in infertility clinics. So first of all, even COVID-19 doesn't have terribly bad effects on fertility per se. So in the clinic, these infertility clinics, their clients are no more or less likely to have had COVID-19 or vaccination. And when they look at people who've been vaccinated, their reproductive system is working no better or no worse than others. And then when they've looked at large populations of people who are not fertile, who are not infertile, because you could argue, well, IVF clinics are an abnormal population. Again, there's no effect on fertility, no effect on the baby. So that's really good news. And in fact, the flip side is true, is that if you're pregnant and catch COVID, it's a really bad story. Both you and the baby do badly. Oh, by the way, just one thing with COVID-19, what they've shown, if you've had the virus, not the vaccine, the embryo they collect with IVF, they find it harder to find a good embryo if you've had COVID-19, but not if you've been vaccinated. But if you get COVID-19 when you're pregnant, really bad news for both mother and baby. And so you want to be immunized. And if you're pregnant, get immunized. Same for influenza. You should be immunized against influenza. These vaccines are safe in pregnancy. And the advantage in getting immunized and you breastfeed is that you pass the antibodies to the baby. So in effect, you can't, it's going to, when they introduce childhood vaccines, it will be from the age of 5. It won't be for young babies. Yes. So if you've been immunized and you've got antibodies on board and you breastfeed, you will pass them to the baby and you will protect the baby. So in fact, it's an imperative to get vaccinated there so the baby's protected against COVID-19. Because the worst time for, although children get it more mildly, the worst time for a child to get COVID-19 is in the first year of life. They don't die, but they can be quite sick. And you don't want that for a newborn baby.
Of course not. That's very reassuring. Thank you, Norman. And in the same sort of context as other safety questions, someone has just asked us, how could someone with anaphylaxis get safely vaccinated?
It's a really good question. And I think the bigger problem is with Pfizer and Moderna rather than AstraZeneca. But some people who think they've had anaphylaxis actually haven't. So the first thing to do is check whether or not you've truly had anaphylaxis. So for example, there's a lot of people going around saying, I'm allergic to penicillin. But when a properly trained allergist looks at them, they're actually not truly allergic to penicillin. They might have had a rash, but they're not actually allergic. So a lot of people are being denied and good antibiotics because they think they're allergic, but they're not. It's not their fault. It's just something they've been told by a doctor that they are, but the doctor might have been wrong. So that's the first thing to do, is check whether you're truly anaphylactic. And look, there are vaccine clinics around the country where you can be referred to, vaccine specialist clinics, who can work this out, or get your GP to refer you to an allergist. There are ways of having this where they're just super careful about it. And when they work out what you're allergic to. But it is possible, but I'm not the person to advise you. You just need, most states have specialist vaccine clinics for just this issue to work out what's best for you.
Okay, that's great. Thanks, Norman. And sticking with the similar sorts of themes, we've got another question or a comment that someone who'd like more information about people that are immune compromised, specifically in an immune suppressant, specifically taking an immune suppressant medication such as Humira, if I've pronounced that correctly.
No, really important question. So immune compromised people such as yourself, not the person who's probably got rheumatoid arthritis or something like that, or an inflammatory arthritis, you're eligible for a 3rd dose now. So you can go to your doctor and get a 3rd dose of either Pfizer or Moderna right now. And you should, to boost your immune system. Now, there are some people in whom, who particularly might have had a heart transplant, a lung transplant, or a kidney transplant, where they're on really profound immunosuppressant drugs. They about 30 or 40% of them get almost no immune response to the vaccine. So it doesn't mean they don't get a 3rd dose. You should try and get a 3rd dose, but you may not get a strong response. And that's where these new antibody treatments, well, not antibody treatments, well, kind of treatments come in, because they provide a temporary antibody cover to protect you. And AstraZeneca has actually produced a double antibody cocktail, which is injected, which may last a year for people who've had an organ transplant, which protects them, because they're going around in fear at the moment. What happens if I get COVID? And they could, they will do really badly. And when this AstraZeneca drug comes on the market, that might be the answer for them, is they might need an annual injection of antibodies. They're very expensive. It's not for everybody. It won't be accessible to everybody. But if the immune compromised group of people can have it, and I wouldn't wait till that comes on the market, get your 3rd dose, because that's the best thing you can do at the moment, and then see what happens with the AstraZeneca drug in particular.
Okay, thank you, Norman. Now, I thought I'd just change pace a little bit and go to a slightly different question again. So a comment here from someone that says, Dr. Robert Malone, MD, virologist and immunologist, is credited for his part in inventing the mRNA vaccine. He recently described this vaccine rollout as the greatest human experiment of all time, and he's called for a worldwide halt. Do you think we should be forced to participate in this experiment, given we don't know the long-term consequences and what they may be? it's the long-term consequences that terrifies me.
Yeah, so he's been given far more credit than he deserves, far more attention than he deserves. He doesn't necessarily have the credentials that people are ascribing to. I don't know what he said about himself, but he's ascribing to himself. As I said before, these vaccines have now been given in billions of doses. If there was a problem, we'd know about it. And there are some problems, and we do know about it. So 1 in 50,000 chance of young men getting an inflammation of the heart. There's a very rare complication called Guillain-Barré, which some other vaccines have, which you can get. There may be a little noise about tinnitus, a little signal about tinnitus, and very rarely in some people. So there are far rarer side effects. But there's no reason to suspect, for example, and this is what some of the anti-vax movement are putting forward, and this is anti-vax stuff, be under no illusion about this, is that that it might change your immune system. This mRNA doesn't get into your core genetic material, your core genes. I wish I had a graphic here, but just imagine a sphere, which is the cell, surrounded by gladwrap, which is the membrane. And inside the cell, there's another area called the nucleus, also surrounded by gladwrap. And it's surrounded by gladwrap because it's the protected part of the cell where your chromosomes are and most of your genes, almost all of your genes. Now, when the mRNA gets into your cell, it doesn't go into the gladwrap bit in the middle, the nucleus where all your genes are, because mRNA is designed for the soup of the cell. In other words, the inside of the liquid that's inside your cell, outside the nucleus, and it sends messages to little things inside the soup, which are the factories which produce more of the spike protein or proteins. Now, if there was a problem with these vaccines that send the genetic messages in, there would be a problem with the virus too. So, for example, all they're doing with these vaccines is mimicking what the virus does, but in a safer way. So if you say, well, this is experimental, we don't know what the effects are, that means if you're not going to have these vaccines, you're going to expose yourself to the virus. That's the fact of the matter. You're just going to get the virus. And that's a dirty process because the whole virus gets inside your cell, creates havoc, and tells the cell to produce more virus. You see, the virus isn't like a bacterium which can live by itself and grow and multiply in a dish. If you throw a virus into a dish, unless it's a very specialized dish, it doesn't grow. It dies. It dies on the table after a few hours, even dies in the air after 3 or 4 hours. It's got to get inside a human body and then inside your cells, inside the shrink wrap, to actually tell how it survives is doing that, and then telling the cells of your body to produce more virus. So if you get the flu, you get the common cold. That's why you feel lousy, you get a fever because the immune system is reacting. You've got a runny nose and the runny nose is partly the irritation, and it's producing more virus to spread into the air, etc., etc. It's an incredibly dirty process. Now, if the doom and gloom predicted by these people were to occur, it would happen with the virus. Now, the virus produces brain damage, heart damage, all sorts of collateral damage because it's the whole virus and it's a dirty situation. And so some of the side effects are similar. So, for example, if you get infected with COVID-19, you've got an incredibly high chance. It's like a 1 in 100 chance of getting inflammation of the heart. Not 1 in 50,000, 1 in 100 chance of getting heart inflammation. There's been no side effects in the brain in terms of vaccines, but you've got a very high chance of brain damage with the virus. It's just a dirty process. Yeah. And so either you're saying, well, I'm happy to get the dirty virus and all the side effects of that, or I'm happy to get a very tiny part of the virus, which is not going to interfere with my genes, and produce an immune response which protects me against those dirty side effects.
Very a very balanced way of explaining that, Norman. Which
And let me say something else.
Yes, certainly.
I've had the Astra. I've not had the Astra just for show. I've had the Astra because I know the data, and I do not want to get COVID-19. I do not want to get COVID-19. When they first discovered that smoking caused lung cancer and heart disease, who were the people who first gave up smoking? It was doctors and nurses, because they had seen it and they knew the facts. And you'd be hard pushed to find a doctor who has not bared their arm, or a nurse who's not bared their arm. Yeah, there were one or two around, but not many. They were lining up and screaming for the vaccine. We know what it does. We're not idiots. We know the science. And, you know, if doctors were abandoning these vaccines in large numbers, you'd say, oh, well, why are they doing that? But they're not.
No.
They're amongst the highest vaccinated group in the country.
Thank you. Norman, given that we're starting to get down to time, very unfortunately, I'll probably just switch gears a little and ask you a couple of other questions, which might be less medical, but we'd still appreciate your view, which is we all know people, for whatever reason, who won't take a vaccine. How do we, as family and friends and colleagues and communities, convince people? And we hope a day like today is one of those opportunities, but have you any other ideas, particularly for that young cohort in their early 20s? You know, people, another question is asking about, have you got any tips for that type of encouragement or influencing?
There are very few of them, really. Canberra has got to 98% of the over 16s, and they'll get to 98% of the over 12s. So in the ACT, it's only 2% of people. It's almost nobody left to vaccinate. New South Wales, 92% have had first dose. You're going to get 90% of people over the age of 12 covered eventually. Same in Victoria. In other states, it's slower because people can't be bothered. Why? There's no COVID around. Why should I push myself, et cetera, et cetera. But they're going to be in trouble because they're eventually going to have to open up. If they open up at low immunization rates, they've got an issue. So I actually think that the hardcore of people who think, well, my arm's going to be turned into a magnet, or they're putting in a microchip and they're going to be following me and it's all 5G, I don't bother with them, to be honest. The people I bother with who've got are the people who've asked some very sensible questions, like on this webinar. Yeah. These are all very sensible questions. People have thought about this, they've thought about it deeply, and they've read about it, and they've got very sensible, legitimate questions to ask. And that's why I've come onto this webinar, because it's to engage with people like you who have got important questions to ask about it and are open to the idea of being vaccinated. And for young kids, it's convenience, it's why should I bother, and so on and so forth. So I think that there are a couple of things that make a difference. So vaccine passports will make a difference. The fact that you can't fly anywhere, and you won't be able to fly anywhere in 2022 unless you're fully vaccinated, internally or overseas, that's going to make a difference. We probably are going to have to maintain vaccine passports, and it'll be a mistake by state governments if they stop those. So if you want to get into a nightclub, you want to do that, you've got to be fully vaccinated. If they've got younger kids in their family, under 12, who can't be vaccinated, then you shouldn't allow them to come in contact with your younger kids, because they're a danger to younger children. The way to protect younger children is to cocoon them in people who've been vaccinated, because vaccinated people have a much lower risk of being infected. And those sorts of things, and then their jobs will make a difference. So increasingly, more and more workplaces will mandate vaccines. And that's what they've done in Western Australia, which is a really good thing, I think, when people are they just need a kick up the bum to get it. They don't need to be convinced. They just need to, get going and be motivated.
A little bit of motivation.
Yeah. Most Australians are really good at this, and they will be vaccinated. And it's just got to be convenient, easy, and you've got to be sure for yourself that it's safe.
And some of our, well, a lot of our staff now in our jurisdictions are having to work to a timeline, which I think for those of us who can work better under pressure to a deadline is probably a good thing. However, it also, I guess, marginalises some people who are not as willing to be vaccinated, which is a very real issue for us as an organisation. And we've got so many questions about, look, honestly, I'd need to tie you down to the chair for a day, I think, Norman, to get through all the questions. But I will, I guess...
The only further thing I would say to people who are not going to get vaccinated, I mean, if you've got an ideological thing, and it is ideological rather than scientific, and you're determined not to, that's fine. But you will get infected with COVID-19, and you're playing with fire. So if you accept the fact that you'll get infected, in the end, when the rest of us are protected, it's on your head. If you're willing to do that, the only problem I've got morally and ethically is that you'll end up, quite likely, in 10% chance you'll end up in a hospital, and you will take up a bed, and you've got a 1 in 50 chance of ending up in ICU. And if there are too many of you, people with cancer, heart disease, who need treatment that's sometimes life-saving for other things will not get it because you're taking up a bed that they need. And that's a bed that was avoidable had you been vaccinated. So if you don't care about that, you don't care about the doctors and nurses and the risk you're putting them to and the stress you're putting the hospital system under, it's on your head. You get COVID-19, go for it. Yeah. But to be blunt, you actually could be killing somebody else, not through COVID, but through neglect in the hospital system, because the hospital system is so stretched looking after people like you who could have had a needle in their arm.
Yeah. Thank you, Norman. And look, I'll just ask one more question. I'm going to sneak this one in, because with the communities opening up more, now that we're getting these amazing vaccination rates, I've got a question here that says, is there a difference in the likelihood of transmission if you're vaccinated or unvaccinated? For example, I'm vaccinated, but out in the community, I just want to know what my risk is of infection and passing it on to others.
Okay, so again, it depends on your age and it depends on which vaccine. But if, let's say, you're under 50, as soon as you're immunized, fully immunized with Pfizer, you've got about a 90% reduction in risk of being infected. Not hospitalization, hospitalization is even higher than that, but being infected at all and be able to transmit it, 90% reduction. If you're one of the 10% who get infected, you're just as likely to transmit it, but you're far less likely to catch it. Now that reduction in risk of being infected drops month by month, which is why you need a booster around about 6 months. But it's still lower. And if you wear a mask, it lowers it to almost zero, because the mask reduces your risk of spreading the infection by about 60%. So that's why teachers in schools, immunized, wearing masks, very unlikely to be passing on the virus to kids in that environment. So that's the answer to that.
Thanks, Norman. And I'm going to ask you one really short and personal question, given you've given us so much energy today, which is fantastic, is, are you drained from constantly having to relay information, talk about the virus and the vaccine, and how do you maintain your motivation?
Well, motivation comes from everybody else. I mean, the fact of the matter is, with CoronaCast, we get about 3.5 million unique downloads a month. So that's enormous, and it's going up, not going down. We thought we'd be able to retire and stop CoronaCast, and it still keeps on going. And people still have questions, and they have need for information, and that need changes. Yeah. And that's what motivates me, is to be able to answer those questions in a dispassionate way. I've got no conflict of interest here. I'm not a government who wants to open up early and do things that we shouldn't be doing. I'm here to actually tell you the facts, and if the facts are unpalatable, I'll tell you them.
Yeah, well, we've so appreciated that today, Norman, and I'm so disappointed we've run out of time, because if it was up to me, as I said, I would tie you to the chair and make you answer more questions. So just being opportunistic, I'm wondering if I was to email you some questions offline that you could answer, if you might pick up a couple more that we've missed today. Not all of them, but a couple of key questions, and then we can share that with our...
Right. I mean, I've got another couple of minutes if you want to do a couple of quick fire ones. Do you want to just pick them up now?
Okay, that would be brilliant, actually. Thank you so much. So just another question about, I think this is just the reassurance people are looking for now that the community is opening up. the latest Public Health England vaccine surveillance report finds higher rates of infection among the fully vaccinated than in the unvaccinated in all age brackets over 30. What are your thoughts on this?
Well, that's what you would expect when the majority of British people are vaccinated. So and we're actually seeing that, beginning to see that in Australia, if you look at the Victorian data, is that when it's only a minority of people who are unvaccinated, they are disproportionate in effect in the cases, but you will expect people in the vaccinated community to start showing up as catching it. And this is in Britain, it's because they've been late to the party on the booster shots. So you've seen waning, and now it's coming back in the vaccinated population. And there's about 67% of British people of the total population have been immunized. So that's the majority of British people. And if they're waning, you're going to see it coming back in those people. And that you need a booster. And that's what they saw in Israel. In Israel, they saw that coming back. And Israel went really hard, really early with a third dose vaccine campaign to the whole population. And they've turned the corner on that. And it's gone back down again. So that's a lot of that in Britain. And the other thing in Britain is that they've not kept up things like mask wearing. They thought they just get rid of everything. And that was a mistake.
Thank you. One other question is, from an employer's perspective, given the declining effectiveness of the vaccines after a few short months, and I know we've talked about dose 3s and boosters, and given that rapid antigen testing is going to become widely available in Australia, wouldn't employing a rapid antigen test strategy be a better mix from a risk management perspective as opposed to mandating vaccines for particular people?
No, I think look, I think that you can go too far with mandating, but I think that any professional group or any group that's face-to-face with other people, particularly vulnerable people, you just can't take that risk. And we mandate influenza vaccine for certain groups as well. And every court challenge to mandated influenza vaccine has failed. Because you're protecting the public good here. So you do need to get vaccine coverage. Rapid antigen testing is not that cheap. I mean, it's $10 or $15 a dose. That's a lot of money when you start adding it up. And you've got to do it twice a week. It's not just once off. It's like you got to do it twice a week to really be sure. It's very good at picking you up when you're infectious, but it's not a replacement for vaccination, and it's not very practical.
Yeah, yes, thank you very much, Norman. Now, I am going to wrap it up just with a comment and a thank you, which is we've got one of our participants who just told us a nice good news story, is that she became pregnant through IVF a week after she had her second AstraZeneca shot. My doctor emphasised it had zero impact on fertility, and she was right. So I think that's a lovely last comment to make. So with that, Norman, I'm going to once again thank you so much for your time and your honest discussion with us. I think you're a very trustworthy person, and I think you're giving independent advice, which is really fantastic. And as you said, you were one of the people who exposed that small risk with AstraZeneca. So I think that gives us a great deal of trust in the information that you've provided us today. And we are so grateful because we do support 23,000 people across the country, and we employ about 8,000 staff, some of them, or the majority of them, being in client-facing roles. So your expertise and your goodwill and making the time for us is sincerely appreciated by Life Without Barriers. So thank you so much.
That's all right. And can I just do a plug here for my book? If you want to break from COVID, because there's almost no mention of COVID in there too.
I do.
It's a book called So You Think You Know What's Good for You, where I've tried to burst a few myths generally in health, and so if you want to find out what's bullshit and what's not, maybe you might find that useful for a Christmas present.
I'm rushing down to the bookstore down the road shortly.
All right.
Thank you again, Norman. And with that, I will thank everyone else for your attendance and your questions. I'm sorry we couldn't get through all of them, but I guess that indicates just how important this session was. So thank you, everybody. And I'll say goodbye for now.
Bye. Thank you for having me.
Bye, Norman.